Hello, my dear students. In today's lecture, we will discuss acrylic resins. Also, the next lecture will cover the same topic. So you will see the acrylic resins in clinical use when you start treating patients in fourth year. You will do some complete dentures in fourth and fifth years. So a complete denture is a removable dental prosthesis that replaces the entire dentition and the associated structures of the maxilla and the mandible. And usually the denture base and the teeth as well are made out of acrylic resins. So we make a complete denture for an edentulous patient, starting with the first step, doing a primary impression for the patient alveolar ridges and associated structures. We then sent it to the lab to make the primary casts, and then we use the primary cast to construct special trays. As you can see, the special trays are also constructed out of acrylic resins, and then we use these special trays to make a secondary impression that is a more detailed and accurate and more fit impression for the alveolar ridge and associated structures. And then we construct bite blocks or wax rims for the patient to get the bite registration or the jaw relation of the patient, using the wax that we discussed in the last lecture. And the denture base usually also made out of acrylic resins. And then we, after we recording the jaw relation for the patient in the patient mouth, we do a try-in for the teeth, and this the relation that we actually record. This is the step, and then we process the final denture. So what's the material of choice usually for the complete denture base? Actually, it's the acrylic resin, polymethyl methacrylate, because it has some desirable qualities such as good aesthetics. It's cheap, it's easy to process. Usually we use the acrylic resins to construct denture-based materials, for denture repair, also some, mostly denture teeth are made out of acrylics. Denture liners, we use them to construct special trays or customized trays, as we discussed, and then the soft tissue replication in the cast metal framework. This is the acrylic denture, and this is acrylic resin. Usually it comes in a powder liquid form. There are different types of acrylic resins. They can be heat cured, cold cured, or chemical cured, microwave cured resins, and light. So the acrylic resins actually comes in two containers, powder and liquid usually, especially the heat cured. When we're talking about heat cured, it comes in two components, powder and liquid. It is composed out of the liquid, usually mainly composed out of monomers, and we can call them MERS as well. It's the single organ molecule that is capable of uniting. So usually methyl methacrylate. monomer. This is the methyl methacrylate chemical structure. And when the methyl methacrylate unites together, molecules unite together, they will form the polymer, which is the polymethyl methacrylate. It's a large number of methyl methacrylate units linked together, as we can see here. The acrylic resins are resilient plastics formed by joining multiple methyl methacrylate molecules or mirs. The reaction is an addition polymerization reaction, converting methyl methacrylates into polymethyl methacrylate. And as we said, it's about them. We should know some terms like polymer is large, long chain molecule formed by chemically joining smaller molecules. The copolymer is two or more different types of monomers joined together. And cross-linked polymers are adjacent polymers that bond together by side chains. As we can see here, this is polymers. Cross-linked polymers when we get some side chains, as we in the structure in B. Here it's a polymer, here it's cross-linked polymers. As we said, the reaction is an addition polymerization reaction. It takes 4 steps. First, starting with activation. The different acrylic resins have different activators. For example, chemically cured, the activator is tertiary. Heat cured, the activation happened by heat, and light cured, it's light. And then initiation, usually the initiator is benzoyl peroxide, decomposed, and then the free radicals are produced. And then propagation, where the free radicals break the bond between the carbon atoms in the monomer, and so the adjacent monomers can bond together. And then termination occurs when the monomer units are used up or the free radicals is tied up by the reaction. It's very important to know the polymerization type of the heat cured or acrylic resins in general. It's an addition polymerization. So as we can see here, the free radicals are free when we get the initiation of the reaction, and then it will break the carbon bond so that we have a free end, so that the different monomer units can bond together. And then propagation, which is the growing of the polymethacrylate methyl methacrylate chain. The other type of polymerization is condensation polymerization. Usually more than one type of polymers are used, and we have byproducts such as water, hydrogen, or alcohol. So you should know the composition of the different acrylic resins. Starting with heat-cured acrylic resins, we said it comes in a powder liquid form. The powder usually contains the pre-polymerized beads of polymethyl methacrylate, which is very important to reduce the polymerization shrinkage. Initiators, usually benzoyl peroxide, pigments, opacifiers, plasticizers, synthetic fibers. The liquid formed out of non-polymerized methyl methacrylate monomer, and the boiling point is 100.8 Celsius. Some cross-linking agents, inhibitors, and we should store it in dark container to prevent occurrence of free radicals and then initiation of the reaction. The plasticizers usually used to reduce the brittleness of cross-linked polymers, so they don't enter the reaction, they just serve as interference for the cross-linking or lubricant between the chains to reduce the brittleness. of the material. Cold cured resins or chemically cured resins, or you can call them also self-cured resins, because the the activator is within the material, which is the tertiary amine. Usually it has a less working time than heat cured acrylic resins, and the viscosity rapidly increases. So we should be careful not to increase the vertical dimension. It has a higher residual monomers, which mean it is less biocompatible than heat-cured resins, and it has inferior mechanical properties. Also, it has inferior color stability because of the oxidation of the amine acids. If you want to compare cold versus heat-cured acrylic resins, it has a smaller polymer beads. Cold curing method actually results in a polymer with lower molecular weight, and then this leads to less strength, more residual monomer, and less color stability. It is allowed to cure at room temperature or warm water. Start to polymerize soon after mixing, and the packing consistency reached in 5 minutes. Chemically activated resins, however, they do have advantage of showing less polymerization shrinkage and more dimensional stability due to the residual stresses during the processing cycle. Microwave cured resins, it is easy to use, very short curing cycle, however it is expensive. And the light cured resins usually used as a denture hard relining material or for repair or construction of the tray. It is composed out of a different polymer urethane dimethacrylate and colloidal silica to control the flow. The photoinitiators and activator is the visible light. It has a high molecular weight, inferior bond strength, especially to the denture teeth. Non-methyl monomer used here, so we can use light cured resins in the patients that have methacrylate allergy or sensitivity. It is less stiff and it has less flexural strength compared to the heat cured resins. There are other types such as fluid resin, which can be poured easily. High impact strength acrylics, usually reinforced with butadiene styrene rubber. Rapid heat polymerized acrylics, it contains heat activated and chemical activated initiators, and it's processed in boiling water immediately. This is the fluid resins. It can be easily poured because it has low viscosity. It's very important to know about the mixing and curing of heat cured resins. We have some students using the material in the 5th year and still not familiar with the mixing ratios and the material properties. Usually the powder liquid ratio should be 3:1. The liquid is poured in one container, then the powder is added. Usually, if you add too little monomer, this will lead to incomplete wetting of the powder and streaked or blanched appearance in the denture. Too much monomer leads to more polymerization, shrinkage, and porosity. Also, you should be familiar with the physical setting stages of the heat-cured acrylic resin. Usually started with the sand stage just straight away after mixing. Then the material starts to be stringy and sticky. Then it starts to reach the doughy stage, like a dough, and you can use the material, work the material during this stage. So it's the working time. And then rubbery stage start to be very rubbery, and then it start to be stiff, and you can use it. You can't use it anymore when it is in the rubbery or stiff stage. So usually the denture is processed, as we said, after you do the try-in in the patient mouth, you send it to the lab. The lab will do a process called flasking. Flasking, because this equipment is called a flask. So we insert the trial denture into the flask to make a mold. The mold will be made out of a gypsum material. So you will end up having the teeth in one side of the flask and the cast on the other side of the flask. And then you do backing of the acrylic resin in the doughy stage. Then we just close the two parts together under pressure. So this is the dough stage, and then you close it under pressure so that you don't have any excess material, and you remove any excess material afterward. So as you insert the denture, the trial denture in the flask, the first step is we need to eliminate the wax in a process called dewaxing. And then once we eliminate the wax, we apply a separating medium over the cast. And then we place acrylic dough. We do backing and removing excess using cellophane paper, and then final backing and during under pressure. You will have a detailed lecture about flasking and heat curing in the third year, next year. We need to do curing under pressure to ensure first we need to do flasking under pressure to ensure flow to all parts and prevent stressed bite and reduce the porosity. Also, the curing is done under heat and pressure. The curing cycles, usually we have two types of curing cycles. Long cycle that we usually use 8 hours in 74 Celsius water, or short cycle at the same temperature but only for 1.5 hours, then followed by 1 hour in boiling temperature. So why 74? Because most polymerization occurs at this temperature. Also, you need to consider that the polymerization reaction is actually an exothermic reaction, which means it will produce temperature and it will raise the temperature. In this section, the temperature is higher, so curing is better, but porosity is more likely to happen. If the pressure is lost during processing, then porosity results in these portions, usually uniformly distributed. It's important to allow slow cooling to room temperature to avoid stress formation. And the use of 1 hour terminal boil is to minimize residual monomer, but if you raise the temperature above the boiling temperature, we know that the boiling temperature for the monomer methyl methacrylate is 100.8, so make sure not to exceed the temperature or to reach the boiling temperature of the residual monomer, otherwise we will have some porosity, especially gaseous porosity. Also, when we are talking about acrylic resin, we should consider the polymerization shrinkage. As I said before, having pre-polymerized grains or beads in the powder will reduce the polymerization shrinkage from 21 down to 7%. And as we've said before, heat generation occurs due to polymerization reaction because it's an exothermic reaction. This can be also reduced by the pre-polymerized beads. We need to consider some properties of the monomers being volatile and flammable. It should be kept in a sealed container. It should be kept in a dark container as well, away from light source or heat source. And no contact should be allowed with polymer beads. Cold cure resins or chemical cure resin is also used for making special trays. Usually it comes in two forms. We can mix it as a doughy material and then apply it over the cast. However, in the third year, you're going to use light cured resins, which comes into sheets, and that you can just adapt it and then light cured it later on. By this, we come to the end of the first lecture. Now we will start the second lecture. So this is part 2 of the lecture. As we said before, if you reach the boiling point, for example, of the monomer, you will get some gaseous porosity. So we have different types of porosity, starting with the contraction porosity. Contraction porosity happens due to polymerization shrinkage. If you have insufficient pressure when packing or insufficient amount of the acrylic dough. Gaseous porosity happens volatilization of the monomer if you exceed or reach to the point of the boiling point of the monomer. Granular porosity usually due to the loss of the monomer, while the resin mix is left to stand until the dough stage is reached. Also, if the resin mix is dry, then we will get some granular porosity. The denture surface here will appear opaque and blotchy. Contraction porosity, as we said, it happens due to the monomer contraction by 20% during processing. So the resin flows under pressure in two spaces created by curing contraction. The excess resin is important to maintain this pressure. Insufficient amounts of resin packed in the flask may lead to voids or porosity. So if you have, this is called underpacking. So if you have insufficient amount of the resin dough, this can lead to voids or porosities. Also, the resin should be packed in the dough stage. If you just delay the packing, you may face some as well. Or if you just if you do packing prior to the dough stage, also you will get the flow too rapidly and the pressure will be lost. So two causes of the contraction porosity: either you have less pressure or you have less amount of the resin. Once the resin is rigid, then we'll get thermal contraction may occur, change from curing temperature to room temperature. This will lead to thermal contraction. Curing temperature for cold cure resin is lower than heat cure resin. That's why we may face less thermal contraction in cold cure than in heat cure. The gaseous porosities usually processing, as we said, involves rise in the temperature to initiate polymerization at first, and then temperature due to the exothermic increase due to the exothermic reaction. The rise in the temperature above 100 Celsius, which is the boiling temperature of the resin, will lead to gaseous porosity. They will form in the thickest part usually of the dentures, and can be avoided. This can be avoided by allowing a slow and controlled rise in the temperature, so that we avoid rising the temperature above or near the boiling temperature of the resin. Also, we may face some processing strains. Internal stress or strain can occur during processes of the resin. If the resin is allowed to relax, then warpage or distortion or crazing, which is tiny surface defects, occur. Some of these stresses might just relieved. However, the thermal contraction might remain. This can be minimized by slowly cooling the flask, as we said, slow cooling up to the room temperature using acrylic rather than porcelain teeth. Also ensure compatible shrinkage, because acrylic teeth and the denture-based material, they are made out of the same material, which is acrylic resin, so there will not be differences in the shrinkage. Sometimes also the effect of the auxiliary materials on the dental polymers can also affect the material and affect the material shrinkage or expansion. For example, the stone and glass that they have, they can expand the impression materials, waxes, the separator, denture cleansers, all of these can affect the properties of the acrylic resins. In general, we should know some properties of the acrylic resins, starting with the most important properties, which is biocompatibility. So any material that we inserted in the patient mouth, it has to be biocompatible. The problem with resins, they have some leachable components like monomer, benzoic acid. They can be degrade and leach out of the dentures in certain conditions. Allergy is mainly associated with cold cure resins due to high residual monomer. And as we said before, if we have a patient with allergy, we can use light cured acrylic resin rather than cold or heat cured. So as a replacement, as we said, denture bases may be constructed out of polycarbonate, vinyl acrylics, light cured acrylics. Also, the pigments can be toxic. The other properties you should be aware of is the dimensional stability and accuracy. So it's important for the denture to be retained in the intraorally. So if there are some dimensional stability, dimensional changes in the denture base, the fit might be inaccurate. So we might face some problem with the retention. So we need to get the denture with accurate fit to ensure good adhesion, large surface area, and cohesion, accurate fit to ensure also good peripheral seals. The dentures might be distorted during processing, finishing, and in surface. So sometimes in the lab, when they process the dentures, we might have some distortion during the finishing of the dentures or when the patient uses them. The mechanical properties also are important. One mechanical property that might be a problem is the creep. It can be minimized by cross-linking agents, and it's more common in heat-cured resin. Also, the dentures are prone to fracture due to poor impact strength, poor resistance to fatigue, especially if you are the patient is wearing a ill-fitting dentures. Usually, vinyl acrylics are tougher than polymethyl methacrylate and permit large deformation before fracture. Vinyl acrylics have higher impact strength compared to polymethyl methacrylate. Also, the abrasion resistance in vinyl acrylics is actually higher. So when we are talking about impact strength and fatigue strength, this can be a problem in the patients that have frequent fractures of the dentures. So in these patients, we prefer to use high impact resistance resins. They contain rubber toughening agents. So this will decrease the crack, but maybe they will have lower flexural modulus, and this will lead to fatigue due to excessive flexure. Also, we can have some resins with incorporated fibers, such as carbon fibers or aramide fibers or glass fibers. The problem with carbon fibers is that it's difficult to handle. It has a poor aesthetics, and it needs some surface treatment to get bonded to the acrylic resins. Aramide fibers readily wetted by methyl methacrylate and it doesn't need any special surface treatment. Also, glass fibers can be incorporated in the denture-based materials as short fibers or loose form. Also, you should be familiar with some physical properties. The thermal conductivity of acrylic resin, usually it is low. It isolates the tissue from temperature sensation. So maybe the patient cannot feel how hot or cold the fluids or foods due to the presence of the dentures. The coefficient of thermal expansion is high, and this affects the fitting of the denture. Also, heat distortion temperature resins deforms above their glass transition temperature. So, distortion temperature for polymethyl methacrylate is 71 to 91 Celsius. Also, they can absorb water and they can have some changes due to water absorption. However, it is insoluble in water fluids, but soluble in ketones, esters, alcohol. And these can cause crazy. Also, some chemical properties, we should be familiar that some kinds of candida albicans may be colonized on the denture surface, and this can be prevented by proper cleaning, denture whitening, denture looks bleached. However, so some patients will actually use bleaching agents on the dentures by hot water, using hot water to soak the denture, or contact with solvents such as acetone, improper networking between polymer beads and matrix phases. All of these will lead to denture whitening, and denture looks bleached, and most of them are actually due to improper cleaning of the denture, like using hot water, as we said, or using some solvents, some improper solvents to clean the denture. This is a bleached surface of the denture. Also, the second part of this lecture, we will talk about the artificial teeth. The artificial teeth, most likely that we use in the dentures, complete dentures or partial dentures, are made out of acrylics because it is cheap, it has good aesthetics, it bonds chemically to the denture base. However, in some cases we can use porcelain teeth. There are some requirements regardless of the type of the material that we use. The teeth that we are going to use, artificial teeth that we are going to use, they should have good appearance. They should bond. They should have good bond strength with the denture base. They should be resistant to abrasion, distortion, or creasing. They should be strong and tough, and they should allow some adjustment when we check the occlusion. And they should be, of course, biocompatible. As I said, we can use acrylic teeth or porcelain. The acrylic teeth produced in reusable molds using dough technique or injection. They are made out of highly cross-linked resin to resist creasing. Pigments can be added to simulate natural teeth appearance. The base and core made out of light cross-linked resins to allow softening when in contact with the monomer from the denture base. Porcelain teeth, usually larger than required molds used to allow for shrinkage during firing. So we use larger molds. Small pins are added to the base of the denture base for retention of the denture base, because porcelain is a different kind of material. If you want to retain it in an acrylic denture base, you will need to use mechanical means because it does not bond chemically to the acrylic resins, while the acrylic teeth, they actually form some chemical bond with the denture base because it's the same material. Both of them are made out of acrylic resins. Also, as we said here, the chemical bond to the denture-based material with acrylic teeth. It's easy to grind because it's not very stiff like porcelain, not very hard. It doesn't wear the natural teeth or the artificial opposing teeth because it's not very hard, so you will not expect the acrylic teeth to cause wear or some kind of enamel loss of the opposing teeth or artificial opposing teeth. It's easily polished, compatible with the denture-based material. However, mainly the main disadvantage of it stains over time. So you will expect discoloration of the denture teeth after using for some time, or if the patient is consuming food with a lot of coloring agents. And it's easily weared because it's not very hard. The porcelain teeth, on the other side, have better aesthetics. They are more biocompatible. No monomers or chemical agents are leaching out of the porcelain teeth. Mechanical retention is needed. As we said, we can use small bends in the denture base to retain the porcelain teeth. It's difficult to adjust because it's very hard and produce clicking sound when the patient bites. إذا كان عنده الupper والlower dentures are made out of porcelain teeth, you'll expect some clicking sound when the patient is showing, for example. It can wear the opposing natural teeth because it's very hard. It transmits greater forces to the supporting tissues, and it is heavy. So as you can see here, this is a plastic. This is an example of ceramic teeth on the left. You can notice the bends, and this is a plastic teeth on the right, acrylic teeth with no bends. Also, the acrylic resins can be used in maxillofacial materials, mostly polymethyl methacrylate, because it's but the problem with it is that it's hard and stiff. We can use polyurethane, room temperature vulcanized silicones. It has good aesthetics, mechanical properties similar to addition silicone. The fabrication of maxillofacial materials similar to denture construction, impression, master cast is board, wax pattern, try-in, investment, and flasking. The most important properties in maxillofacial materials, it should be have a good tensile strength. And here a prosthetic nose, a prosthetic eye. Also, we use acrylic resins and denture lining materials. Denture lining materials are divided into hard reline material, semi-permanent soft reline material, temporary soft line material, and tissue conditioners. For hard reline material, they should have certain properties. Usually, there are a certain indication to use hard reline materials. First, if the patient comes with a poor retentive and not stable denture, loss of vertical dimension, if we have degradation of the denture base, for older patients for whom getting used to a new denture base would be difficult, so we may just do hard reline for them. Lack of denture extension into new buccal fold areas, especially important for facial support. The material used for hard reline: heat cured resin, usually in the lab; cold cured resin, chairside. The disadvantages: poor taste, poor color stability, exothermic reaction, lack of control over amount of denture removed, and thickness of the reline. We have two types of cold cured resin that can be used: type 1 and type 2, and each of them has different monomer components, and they come into powder and liquid form. Temporary soft lining material, it's similar to tissue conditioners in application and composition. However, they are not as soft as tissue conditioners, but they can be or they can remain soft for up to a month or two. They are slightly viscoelastic. We use them when frequent replacement of conditioner is not possible, to ascertain if permanent liners would be beneficial or not, to improve the fit of the denture until a new denture is made. However, we have a problem with their maintenance because of they are soft, they are prone to more contamination in the patient mouth. Permanent soft liners, we use them if there are discomfort or soreness from an otherwise satisfactory denture, last up to 6 months. This discomfort usually associated with the mandible due to small surface area, possibility of sharp, thin, resorbed ridges. The soft liner actually absorbs some of the masticatory forces and then reduces the pain and the discomfort for the patient. The material should be rubbery, resilient, adhere to the fitting surface. It has low elastic modulus and non-toxic and non-irritant. The plasticizers actually plays an important role in soft relining materials. They act as lubricants for polymer chains. It makes it easier for them to slide over one another, so the material can deform easily and absorb the stresses. The available material for soft lining, we have cold cured, which harden in a few weeks. Heat cured can be processed in the lab, also comes in powder liquid form. Silicone can be used, but the problem is that it has very weak bond to the denture base. Also, it encourages Candida albicans growth. The main advantage, it is permanently soft and it's elastic. It can be cold cure and heat cure as well. Polyphosphazine also can be used. There will be a whole lecture, I think, in the 4th year about relining material and denture-based materials in general. Permanent liners, also we can use acrylic soft liners. They can bond to the denture base. The main disadvantage, the plasticizers can be leached out, and when this happens, the material or the lining material will be very stiff. This is an example of long-term soft liner material. So some relative merits of soft liners. Silicone rubber is highly resilient, retains softness, as we said before, requires bonding agents susceptible to growth of the Candida albicans. It has weak bond, poor tear strength, and no permanent deformation. The acrylic is less resilient, goes hard with time. It's more resistant to bacteria, permanent bond, acceptable tear strength, but it is susceptible to creep. The tissue conditioners, usually we need them if we have a traumatized or injured tissues or ulcerated. So we do functional impression. We use the tissue conditioner. It's soft material applied to the fitting surface of the denture to allow better stress distribution. Usually composed of polyethyl methacrylate, ethyl alcohol solvent, and plasticizers, need to be reduced after few days due to leaching out of the solvent and the plasticizer. Requirements of the soft or the tissue conditioner: it should be soft and resilient. It has a degree of permanent deformation for functional impression purposes. The disadvantage, we need to replace it frequently. It's prone to microorganism colonization, prone to damage by denture cleansers. Usually we mix the tissue conditioner freshly applied to the fitting surface, then we seat it. We should inspect it after 2 to 3 days. The material will be initially viscoelastic and soft, and then the plasticizer will start to leach out, so to make the material hard. It will provide a cushioning effect and stress absorbing effect, and it's non-irritant. This is a short term soft reline tissue conditioner because it flows and adapts to the tissues as they heal. Also, we can use acrylic resins for denture repair. We can use chemical cured acrylic materials. If we have pieces, you can fix them together by sticky wax. The plaster is poured to stabilize the denture, and the fracture site usually drilled and freshly mixed. Fresh acrylic is exposed, and then we mix acrylic resin and we add it over the fractured part, and the excess is removed, and then the denture is polished. We can use also light cured repair materials, same procedure as chemical cured, except that the fracture site is treated with a liquid to prevent oxygen inhibited layer of uncured material, which will be difficult to polish. After we repair, the denture is placed in light curing unit to allow curing of the acrylics. So by this, we finished the two lectures. If you have any questions, please contact me on Teams or my email. And I hope you enjoy it. Good luck in your final exams. Thank you.